Okay.
Well, we all recognize the speaker, so I guess we don't need to wait to do the administrative pieces here. So just the basics. I'm Natalie Berger. My job is the Meaningful Use Project Manager at Cadence Health in Chicago. And Dr. Mostasari, my boss asked me to put in a good word for us because we're still working on stage 1. For everyone else, I think you probably know how to silence your cell phone now. I did hear one go off on the last session, so if I could just remind you to please do that. A couple of administrative pieces. If you want to get the handouts, they're not yet online, so please do look at HIMSSconference.org handouts maybe later in the day or tomorrow. If you want to provide your information for your valuation, it's at HIMSS Conference Mobile, and if you want continuing education credits, it's HIMSSconference.org/CE. So other than that, I'd like to introduce our illustrious guests that I know we're all eager to hear. Travis Broom is a policy analyst for the Centers for Medicaid and Medicaid Services. Elizabeth Holland is the director of HIT initiatives in the group of the Office of eHealth Standards and Services at CMS, where present focus is the Recovery Act's Healthcare Electronic Record Incentives Program. She's worked at CMS, formerly Healthcare Financing Administration, for over 20 years, and has held positions in physician payment policy, Medicare contractor management, and HIPAA outreach and compliance. Dr. Farzad Mostashari serves as the National Coordinator for the Health Information Technology within the Office of the National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services. He joined ONC in July of 2009. Steve Posniak is the Director, Federal Policy Division at ONC. And now a round of applause for our guests. Thank you.
I'm not going to make a joke because I don't think you guys could take it. The Stage 2 Meaningful Use and Certification Criteria and Standards rules went to the Office of the Federal Register this morning. They're going to be... And we didn't want to ruin your time here closeting yourself up with the reg text. We want you to be out there enjoying yourself. So it's not going to be actually posted till tomorrow. Aww. It just takes that long. But we have gotten approval to talk about it in some specific detail. So we'll give you the highlights today. We're even going to show you some of the reg text language in certain, for some of the new measures. But in terms of really getting into the weeds, that's going to have to wait till tomorrow. But we want to tell you however much we can tell you as soon as we can possibly tell you, and that is right now. So we're going to tell you what we can tell you. And there's a lot here. So here's the main message, I think, that people are going to take away from this is that we stayed the course. There's a lot of folks who've been following the Health IT Policy Committee and Standards Committee discussions. There's going to be a lot that's familiar. We're going to see a lot of what we are proposing is as a result of that very rigorous and I think really one of the best working Federal Advisory Committee processes in the federal government. So what you're going to see is, in very, very large part, exactly what you would have expected to see based on the Health IT Policy and Standards Committee recommendations. And that's a good thing. There are some things we want out-of-the-box thinking. Probably your regulators are not one of those. So you'll see a lot of predictability in what's going to come out in the rules. A lot of what is there is because we listened and we learned from what all of you have been telling us as a result of stage 1. So listening carefully, and I think you will hear that in the points we make today. There's going to be, one of the things we heard is Adoption is good. We've seen remarkable increases in adoption of electronic health records, both on the part of outpatient providers and hospitals. But what about exchange? And we're going to see a reflection of that, of the feeling that we can't wait 5 years to get standards-based exchange in this rule. By 2014, we're going to see, which is when Stage 2 will come into effect, surprise, surprise, we're going to see a big push on standards-based exchange. There are going to be, and we'll get into what some of those details are, but one of the main messages that's going to come out of, if there's something that, if a regulation conveys a message, the message of this one is, here we come, interoperability and exchange. There's going to be a push on patient engagement. You're going to see a push on that, as per the recommendations of our policy committee. There's going to be a push on patient safety in hospitals with electronic medication administration records. And there's going to be a push on continuous quality improvement, and in particular, clinical decision support tied to quality measures and in support of important priority goals for the practices and with evidence base. On the other hand, we take very seriously the President's executive order to increase flexibility and reduce regulatory burden. So while we're pushing on the outcomes that we seek around care coordination, around patient safety, around patient and family engagement, and around quality improvement, we're going to see that we've really, in many parts throughout both regs, we have done whatever we can to increase the flexibility and to reduce the burden of these regulations, and we'll see some examples of that. Let me talk a little bit about the exchange, and we're going to hear more from our CMS colleagues on that. But we have really pushed on standards in the certification criteria, standards and certification criteria certification rule. There are standards for transport. There's going to be, and I think this is not going to be a surprise to many, the direct protocol will become a required part of certified electronic health record technology. We're also providing for optional certification to the SOAP approach for information exchange. We are pushing for the first time in our nation's health IT history, we have a single standard, consensus standard, for patient care summary, the consolidated CDA. For the first time, we have a single standard for laboratory results in the LRI. We have messaging standards for public health, vocabulary standards, including a single standard for problem list, SNOMED. LOINC, CVX, and more. Info button standard, HL7 info button standard for retrieval of reference information. Quality data model for the data needed to calculate quality measures. Synchronized clocks, and more. There's a lot of interoperability that's going to be added into the 2014 edition of certified EHR technology. We're seeing, I think, the infrastructure laid for widespread and rapid adoption of information exchange, actual boots on the ground information exchange throughout our country. And in reflection of that, we're proposing a push, a very ambitious target in terms of exchange, actual exchange, not a test of exchange, but actual exchange of data across organizational and vendor boundaries. Across organizational and vendor boundaries. On patient-centered care, we're replacing patient copy and online access with the ability for patients to view, download, or transfer their records, and including requirements around secure messaging, something that people are increasingly expecting. We're pushing on decision support, as I mentioned, from up to 5 decision supports tied to quality measures with evidence-based being visible. We're pushing on safer care, as I mentioned. And population and public health, it's no longer just a test of submission of public health measures. It's actual, ongoing submission of public health reports, except where prohibited or where the health department cannot accept those measures. And we're adding as a menu item reporting to cancer registries. There's an increased emphasis on encryption at rest, on privacy and security side, and a multitude of certification criteria that help increase the ability of providers to keep their patients' information private and secure. And we propose important new requirements for vendors around usability and safety reporting that we'll hear about. We've provided a lot of thought to the specialists who, the feedback we got from specialists after stage 1, and we've included many important flexibilities for specialists. Everything from scope of practice exclusions from certain vitals collection, flexibility around defining what constitutes an encounter, for example, addition of menu items relevant to specialists, including reporting to professional society and other specialty registries. We've also proposed, as a menu item, the viewing, I expect wild applause to break out here, viewing of images as an optional menu item for meaningful use. And on clinical quality measures, again, something that we've heard a lot about in stage 1, we have really worked very closely with colleagues across the federal government to make sure that measures are aligned across different programs with the physician quality reporting system, the inpatient quality reporting system, accountable care organizations, patient-centered medical homes from NCQA, Joint Commission, and so forth. And even deemed reporting, if you report for an ACO or report for PQRS or IQRS, having that count. Enabling group reporting of quality measures. So if you have a practice with 10 providers, not having to report quality measures if you choose for each individual provider, but being able to report on a group basis for those quality measures. And there is a long and I think very thoughtful section on the certification rule around quality measurement. What are the pieces to certification that we need to ensure can yield what we expect will be available in 2014, which is reliable and accurate quality measures from electronic health records. And as anyone who's done this knows, we're not going to get there until we try. And we've tried and we've seen all the different parts of that process, everything from data collection, data export, calculation, and reporting that goes into that. We'll hear about flexibilities, the extension of stage 1 until calendar year, fiscal year 2014, retaining the 90-day reporting in the first year. Everyone gets to be, as we're proposing, in stage 1 for 2 years before moving on to stage 2 for 2 years. And avoiding the payment adjustments. We'll hear about that. We've really tried to be as flexible as possible. And on the vendor side also, on the certification side, permitting Gaap certification for 2011 edition certified products. The flexibility, and I expect wild applause here. The flexibility, as Steve will describe, to have only the EHR technology needed to demonstrate meaningful use in stage 2. And other flexibilities you'll hear about. So, in conclusion, I think what you'll see in our description today and in the rule itself tomorrow is we've stayed the course. A lot of what you're going to see is no dramatic change in direction. It's still the framework. It's still really continuing. Most of what we're doing is continuing what's in stage 1 and getting better at it. And if there's one thing that we've all learned, it's that to make truly meaningful use of meaningful use takes time. And this is going to be continually making better use of meaningful use as a tool for you to help improve care in our country. Higher quality, safer, more efficient, more coordinated, more patient-centered care. Thank you.
Okay, so yesterday we were talking about today, saying that we were very hopeful. Today, we're on track to go on display tomorrow, but I know you're disappointed. It's a very long rule. It will be shorter once it's set in the Federal Register, but the way display works is it's on display in a sort of like a Word format, and so it will be much larger than it will be when it is in the Federal Register. I would be remiss at this moment to stand up here just alone and not acknowledge the people who have helped us get here. Just in the last week, people working long hours and all last weekend, and I need to point out just a couple people, Travis Broom, Robert Anthony, Jess Kahn, and tons of others at CMS who we've been working on this since at least probably April, and so we knew when HIMSS was. We were really trying hard to get it out many weeks before today, but things don't always work out exactly how you planned, but now we're really excited that there will be a document out very soon. So today we're going to do like a tiny little bit, not even a Cliff Note version, I'd say. Tomorrow we're going to do a much deeper dive, and so there's a number of sessions that Travis is going to mention where we'll talk more about particular parts. So the one thing I'd really like to say is that we're looking for your comments. You might remember when we did the stage 1 rule, we did change it massively from the proposed rule to the final rule. And we are looking to know what you like and what you don't like, what's good and bad, if there's anything bad. But hopefully it'll be mainly good, but we need you to be balanced. The other thing is when it goes on display, that doesn't start the clock ticking for 60 days. It's actually when it gets published. And we won't know, I'm not sure if we'll know tomorrow or the next day when the publication date is. And it will probably be sometime in the future because the rule is quite large, but you'll have extra time. So don't worry, enjoy HIMSS. Don't worry about reading everything all at once because you'll have ample time to comment. And as you see, we have blanks because of this. So as far as I'd mentioned, we're building on stage 1, but we are also proposing some minor changes to stage 1. And in the proposal, we are proposing that those changes would take effect in 2013. The stage 2 would begin in 2014. Everybody starts in stage 1, so everybody will still have 2 years of stage 1, and then people would start with a year reporting period of stage 2 in 2014. We have lots of new clinical quality measures. Some are totally ready, some are not totally ready, but we're working very hard to get them ready by the time we do publish a final rule. We are targeting the summer for a final rule. There is a whole section in the rule about appeals and how we will be handling appeals. Details on the payment adjustments, these are statutorily required. So we have to lay out how we plan to apply those payment adjustments. There are minor changes to both Medicare Advantage and to Medicaid. This is our famous slide. I'm sure you've seen it many times before. As I mentioned, the timeline. And this is echoes what the Secretary had announced several months ago, that we are giving people who started in 2011 an extra year at stage 1. The other thing I'd like to point out as well is we are proposing a batch reporting methodology for EPs so that you would be able to upload all your data. So comment on that if you like it, if you don't like it, because we need some sort of support to make sure we're going in the right direction. Let me just see. Okay, so we did keep things the same. So you'll notice there's the same number of measures as we move from stage 1 to stage 2. However, the measures aren't all the same. We've moved things from menu to core, we've collapsed some measures, and we've also added some new measures. So I'm going to let Travis talk more in detail about what the measures are going to look like, but thank you for being here.
So I obviously won't have time to go through all the measures right now. We're really just going to highlight the measures that Farzad kind of mentioned earlier in general. We're going to show you what those measures actually look like. There's, as far as the PSA part of this, so as we hope the rule will go on display tomorrow. There's 3 sessions tomorrow that we'll talk about stage 1. There's going to be a meaningful use deep dive in the morning with where we're also going to go over the Medicaid changes.
Stage 2.
Sorry, stage 2. Sorry, thank you.
Stage 1 is so yesterday.
It literally, because I was giving this presentation about stage 1 yesterday. So stage 2, meaningful use and Medicaid changes in the morning, and then we're going to have a session focused on all the health information exchange, both the public health side and the provider-to-provider side. And then we're going to have a session with Maria Michaels and Jess as well down on clinical quality measurements. And then Friday we get to talk about everybody's favorite topic in the payment adjustments. So that's kind of the layout before, and then CMS and ONC, we have our booth, and we're obviously all around. All right. So electronic exchange. So this is the actual measure for what Farzad mentioned earlier. So that, your EP or hospital, it's the same framework, right? So we're really focusing on when you send someone to someone else. So those transitions and referrals, again, like he said, with no organizational affiliation and using a different certified EHR technology vendor than the sender, the recipient, for more than 10% of the transitions of care and referrals. The stage 1 measure, if you remember, was 50% of transitions in care have that summary of care moved in any fashion, paper, HIE, however you can get it there, but do that care coordination. That measure does remain as well, and we're proposing to bump it to 65%, but this is the new part of the measure that really focuses on that actual electronic health information exchange that we all so desperately want. So this is the patient engagement. This is the view, download, and transmit measures. These will kind of take over for the measures that we have now. So the e-copy of discharge instructions, the e-copy of electronic health information, the timely electronic access for EP, all get subsumed into the view, online, download, and transmit. Again, 2 parts. The very familiar part with the 50% have that information available up on the portal. The new part is the real engagement part. We're asking that you ensure that at least 10% of the patients actually do one of those 3 things, either view it online, download it online, or transmit it to a third party. So this is a brand new objective for stage 2, right? Stage 2, electronic medication administration record, this is proposed to be part of the course set for hospitals, not the menu set. More than 10% of the medication orders created by authorized providers of eligible hospitals. So this is really, focusing on that patient safety, patient efficiency aspects. This is the move from the ongoing submission, from the test environment that's caused, probably so much consternation, successful ongoing submission as opposed to test. So you'll still have your exclusions. If you don't do immunizations, don't worry, you still don't have to report information you don't have. And also there is the state readiness piece, but we are moving on to that actual reporting when it's possible. Speaking of tests, one of the stage 1 changes that is a proposal is we're basically proposing in 2013 to just go ahead and eliminate the electronic exchange of test of electronic exchange of health information. It's caused, raise your hand if you've had a question about that one, right? Right, okay. But we're not because we don't believe in it. We're in stage 2. Everybody's, going to be moving on to stage 2. Stage 2, you got to actually be doing that a lot. So here's guessing that you might want to do some testing in stage 1 anyway. But the actual mechanics of that measure we're proposing to remove. As far as I mentioned, imaging, this is the actual measure for imaging. More than 40% of all scans and tests whose result is an image ordered by the EP or by somebody on behalf of the hospital are accessible through. I can't go through, we try and define that term in the NPRM, both on the CMS side and the ONC side for certification, so please read that carefully and let us know if you think we got it right or how we need to improve that. But that's the measure for imaging, and that is in the menu set. And then there's 2 measures now for registry reporting. One focused on cancer registry reporting, and then the other specialized professional registration. Again, these are menu objectives, but we are focusing on ongoing successful transmission in both of those cases. Really, the reason they're split is because the cancer registries through CDC have a lot of specifications and things like that you don't have that corollary on specialized registries as well. These are the comment guidelines, electronic submission. We prefer 60 days after that period. Balance your comments if you can. Tell us what you agree with and whatnot. I don't have a slide on it, but I will say a quick 3 things about the payment adjustments. Same definition of meaningful use as the incentives. There's one definition of meaningful use. There's one timeline. The timeline Elizabeth showed, that applies whether you're going for the incentive or you're going for the payment adjustment. And then we are going to do a prospective, or proposing to do a prospective determination of the payment adjustments. As it's proposed, the latest you would need to attest if it was your first year to avoid the 2015, if you're a doc, would be October 1st, 2014, so 3 months before it would hit. Hospitals, same 3 months, but it's on the fiscal year, so you rotate it from to July 1st, thank you, 2014. So same definition, same timeline, 3 months before the year starts are really the big 3 take-homes for payment adjustments. And with that, I'm going to turn it over to Steve to let him talk about the ONC rule, assuming I can get his presentation up.
Rock and roll. It's been tough sitting there just waiting to present. And Farzad stealing a little bit of my thunder. That's good. I'd rather come from you than me. So I'm Steve Posnack, Director of our Federal Policy Division. There's other people that I'd like to thank too that are on our team. Michael Pinsky, who's not here, but is on my team that does a lot of the drafting for the regulation. And he's one of the reasons why we got it done with the small shop that we have. So without further ado, I am going to talk with you today about the fresh look that we took with respect to our policies, the flexibility that we're proposing to introduce, and the clarity that we're trying to bring to the regulatory process to make it more understandable and more intuitive for you to track the programs. And I think it's important to realize, and this may have gotten lost in the shuffle of the first stand-up of the program, that the EHR Incentives Program is built on 2 rules, and actually 3 rules. CMS's rule, our Standards and Certification Criteria rule, and the Certification Programs rules. And so I think folks paid a lot of attention to the meaningful use rule the first time around and may have gotten caught off guard with some of the policy issues that we discuss in our Standards and Certification Criteria rule, especially the definition of certified EHR technology, which CMS just cross-references in theirs. So it's important that you may not think you're the technical person, and that's okay. You can kind of skim through the certification criteria, but there are other policy issues in the ONC regulation that will be important to both the provider community and to the EHR technology developer community. So I'm going to go through a little bit of our, some of these I'm going to scan through. Born and raised in Long Island, so you're going to get the New York Minute version of my presentation. And, like I will be, the Vegas joke, I'll be here for the rest of the week, I guess, not all week. Tomorrow at every one of those presentations, going into a little bit of a deeper dive for some of these things as well. So I'm going to touch on some of the major highlights, some of the vocabulary that we use that Farzad's already alluded to with respect to how we're talking about the provisions in our regulation, and then continue through. So a brief regulatory history here, and this is really my regulatory history with ONC. We've been busy. Since the first final rule was published in January of 2010, we've now published 10 regulatory actions in 2 years. And with this new standards and certification criteria, NPRM, we're up to 4. With that one, and we had 5 for the certification programs, as well as an ANPRM on metadata standards. So, first new vocabulary lesson. We have 2 different, as we move into this new paradigm, in the July 2010 final rule on standards and certification criteria, we adopted certification criteria in sections 170, 302, 304, 306, related to specific settings, ambulatory inpatient, and just generally applicable certification criteria. To make a clear distinction between these previously adopted certification criteria and the ones discussed in this proposed rule, we refer to those 302s, 304, 306s as the 2011 edition. So you'll start to hear me talk about the 2011 edition compared to the 2014 edition of certification criteria. We, as you can see, purposely chose a section in our regulation that will hopefully make it easier for people to remember where the 2014 edition certification criteria reside, section 314. And one of the things that we did in consolidating down those different setting-specific certification criteria were to group them into, as far as our mind is concerned, some logical groupings of what those certification criteria are meant to represent. And the other one thing I do, just to note, that I've thrown in some crude totals of the amount of certification criteria. So for 2011, we had 41 plus 1, which was optional. In the 2014 edition, we have 50 proposed plus 1, which is still optional. That being said, I wouldn't submit this to any scientific journal. We've split some certification criteria. We've converged and merged some of them. So it's not a true one-to-one match in terms of total. So I wouldn't draw any conclusions out of the number itself, but just to give folks perspective. Okay, so I'm going to fly through these pretty quickly. What makes something a new certification criteria? It only specifies capabilities that were never included previously in a certification criterion. And there's other parts that are just too detailed to go into this one. Many of them support the new meaningful use objectives and measures that some of which Travis went through. Others we determined that are specific to certification and EHR technology, and we've included them as part of our certification program. So moving on. Revised. There are a couple of factors that make something a revised certification criterion. The first being that it includes changes to capabilities that were specified in previously adopted certification criteria. So e-prescribing in the ambulatory setting is an example. We've just proposed to certify on NCPDP script 10.6, reference the use of RX norm as the vocabulary for medications. That's a revised certification criterion because the previous one in the 2011 edition didn't include that requirement. Moving on. So then we have unchanged certification criteria. So we have 3 different types of certification criteria that we include in our rule. Pretty simple. new, revised, and unchanged. And these are the ones where, for all intents and purposes, the capabilities that they've specified in the certification criteria remain unchanged. We've done a few kind of wording substitutions to hopefully make them clear, use more plain language as part of the certification criteria, use consistent terms in each of the certification criteria throughout the entire regulation. And so as far as I'd mentioned with respect to Gaap certification, that's an element that's part of the permanent certification program, which will be up and running and effective when this final rule is published. So the temporary certification program, as many of you are familiar with, and the ONC-ATCB acronym, that is still up and running until the final rule for this standards and certification criteria rule is published. With respect to Gaap certification, that focuses on the difference between certification criteria that are adopted through rulemakings at different points in time. So when there's a carryover from 2011 edition to the 2014 edition, vendors would be able to use prior test results from their 2011 edition to meet those certification criteria that are unchanged. And roughly, kind of crude estimate again, there's other numbers that go into this, 40% of the certification criteria that we include in our proposed rule are quote-unquote unchanged. So that's an efficiency that we will hope will introduce into the permanent certification program and for certification going forward with respect to 2014. Okay. This is where we get to the audience participation section in terms of cameras, pictures, applause. Not this slide, but the next one and the ones that follow. So, redefining certified EHR technology. For this presentation, I'll focus a majority of my remaining time on our proposal to redefine the meaning of certified EHR technology. This is a defined term in the regulation. Not any old EHR technology that's been certified by an ONC-ATCB or an ACB in the permanent program constitutes capital C, certified, EHR, capital T technology. And so the definition as it's structured today is tied to a set quantity of certification criteria. So you need to hit 100% when you're going through the certified HCT products list to get that CMS EHR ID reporting number, regardless of the meaningful use exclusions that you may be able to meet and regardless of the menu objectives that you choose to defer. That's today. If there's one thing that we've heard more than anything else, it's been about the definition of certified EHR technology and why folks can't just have the EHR technology that they need to meet meaningful use. So I will say, my friends, you will soon get what you've been asking for. And you will get to read much more about it when the rules are publicly available. So we got feedback on this issue, both from the community and the HIT Standards Committee, and we are proposing to revise this definition to offer more flexibility for providers starting with the 2014 EHR reporting period. More specifically, that the definition would no longer be based on a set number of certification criteria, but would now be driven by how an EP eligible hospital or critical access hospital chooses to accomplish the meaningful use stage that they need to meet. So this would accommodate instances where, in most cases, this is going to be an EP scenario with respect to scopes of practice, that they can meet meaningful use through an exclusion. And so rather than being required to have EHR technology when they can legitimately meet that exclusion, they would no longer need to have the EHR technology certified in that instance. It would also apply in, all right, there you go. I planted Jess over there. And so, and that we hope will really help with respect to a lot of the specialties and the EHR technology developers that supply EHR technology to those specialties. I'll get into more of this in terms of how it builds. With respect to the menu as well, this definition will also be dynamic to be flexible so that if you're a provider that's seeking to achieve meaningful use, whether it be stage 1 or stage 2, you'll only need to have the 2014 edition EHR technology that's relevant to the meaningful use objectives and measures that you seek to meet. And as far as I'd mentioned, just as a quick note in terms of the continued progress towards increased interoperability, we have moved and converged to single standards in a lot of the places where we previously had optionality, and so that's another area where we're focusing. So here we get to the animation. You haven't gotten any yet. Okay, so here's what certified EHR technology looks like today. And Forgive me for picking the blue button. It has no relevance. It has no relevance to the blue button. Blue just happens to go with our slide motif, so I stuck with that. It's one thing. It's 100% of the certification criteria that we've adopted. Here's what we're proposing. A dynamic version of certified EHR technology that starts from the center with a core fundamental set of capabilities that everyone's EHR technology will need to include. And we talk about that, and I'll go through this a little bit more. It will be called a base EHR, which is a definitional term, and I'll explain in a little bit. It's important to just stop here and remind folks that the definition of certified EHR technology, and this is why I preface this with respect to reading ONC's rule as well, is that it doesn't speak to just one audience. It speaks both to providers in terms of it informs them of the EHR technology that they must have to demonstrate meaningful use, and it speaks to EHR technology developers in terms of the potential market demand for certain EHR technologies that they'll need to seek to get certified, and what their customers will need to meet meaningful use. So there's really two sides to this coin, and we're trying to structure the definition to support both aspects and provide this flexibility. So keep these two views in mind as I go through the remainder of the presentation. Okay, so base EHR. This is part of our fresh look. Starting in 2014, the 2014 EHR reporting period, every provider, EP, eligible hospital, critical access hospital, will need to have EHR technology that's been certified to the 2014 edition certification criteria, and that's assigned to the definition of a base EHR, and I'll get to that next. That doesn't mean you have to go out and buy something new called a base EHR. It's a regulatory construction that helps us communicate the policy outcome that we're seeking to achieve. It means that there's a fundamental set of certification criteria to which every provider's EHR technology must be certified. And that's a starting point. So that's the center of that bullseye, and I'm going to be using the bullseye term because that's what I described. And finally, folks are familiar with, we have two different types of EHR technology certifications, the complete EHR certification and the EHR module certification. The base EHR, again, is built on a certain set of capabilities, so you can meet the definition of a base EHR with a complete EHR, obviously, or with a combination of EHR modules as well. It's really dependent on the capabilities and the certification criteria to which the EHR technology is certified. So again, it's not this specific finite construct that needs to be represented. You need to look at it from the perspective of these are a core set of certification criteria and capabilities that your EHR technology will need to have. Okay, so these are the certification criteria in the 2014 edition of certification that relate to the base EHR. Now, the base EHR is not a strange concept, and you'll see that the statute, the HITECH Act, actually included a term called a qualified EHR. For those of you that are familiar with other CMS programs, there's something called a qualified EHR with respect to PQRS. So we chose not to overload and use that term. We thought that a base EHR was a more communicative example, more plain language. And the first 5 rows of this table represent statutorily defined capacities that Congress said a qualified EHR, what we're calling a base EHR, needs to include. And we've assigned a minimum set of certification criteria and the capabilities to those capacities. We've also, as far as I'd indicated, pushed the privacy and security certification criteria and those capabilities into a provider's base EHR, and that correlates with another change that we've included in our proposed rule with respect to increasing flexibility. So we wanted to make sure that these certification criteria could apply broadly, as broad as possible, since we're expecting that all healthcare providers that seek to achieve meaningful use will need to have this as a starting point. Okay, so I'm going to stick here for a little bit. This is one where if you have video or you want to take a picture at the end, you can. So building outward, as I talked about this dynamic proposal for the definition of certified EHR technology, starting with the base EHR, an eligible professional, eligible hospital, critical access hospital must have EHR technology with the capabilities certified to meet the definition of a base EHR. This is where things start to diverge. With respect to the meaningful use core, an EP, EH, CAH would need to have EHR technology with capabilities certified for the meaningful use core objectives and measures for the stage of meaningful use they seek to achieve unless they can meet an exclusion. And so this is where if you're practicing in a particular scope of practice and you can meet an exclusion and you know 100% guaranteed, and the vendor that supplies you EHR technology, they won't have to get certified to that certification criteria, and you won't need to have that EHR technology to meet the definition of certified EHR technology. Finally, with respect to the meaningful use menu, this is the finale of my build here. There's no fireworks or anything afterwards. The menu is really the most dynamic, which is where the provider, I'm just going to say eligible providers, would only need to have EHR technology with capabilities certified for those menu objectives and measures that they seek to meet. And so no longer is the definition of certified EHR technology built to this set 100% amount of certification criteria. It's driven by the meaningful use stage that the eligible professional or eligible hospital or critical access hospital needs to meet. And that's going to be an area where markets is going to need to react. Vendors are going to need to supply the EHR technology in ways that can meet providers' different pathways. I recognize that it's not going to be a one-to-one fit all the time, and we include that recognition in our regulation. And it's going to be an area where supply and demand need to be met, and we think that that will be worked out in a logical fashion in terms of what people seek to achieve. So moving on, with this new flexibility and the dynamic definition with the bullseye, there would now be 3 ways to meet the definition of certified EHR technology. So previously, you could meet it with a complete EHR or a combination of EHR modules that met 100% of the certification criteria. Now, if you want total assurance, you can meet it with a complete EHR, which is, again, still all the certification criteria that are represented in the 2014 edition certification criteria. So it's a bigger definition now of what a complete EHR is going forward in 2014. But now with the bullseye and the additional flexibility, you can meet it with a combination of EHR modules or a single EHR module now that includes all the capabilities required to meet a base EHR, all of the meaningful use core capabilities associated with certification, absent any exclusions that the EHR technology developer knows that their providers won't need, and also absent any of the meaningful use menu set certification criteria connections that they won't use to meet meaningful use. So this is another one where if you want to take a picture, it's in our rule. As Farzad and Elizabeth and Travis discussed, with the extension of stage 1 for another year, the 2011 edition certification criteria will still be in effect. We've included a transition period, and that's a modification to the definition of certified EHR technology to recognize that there will be rollouts of upgrades to the 2014 edition certification criteria at the same time during 2013. And so we're permitting that people can have a hybrid of the rollouts at that time and still have something that meets the definition of certified EHR technology. Through 2013, though, it's still rooted in the 100% of certification criteria to the 2011 edition. And we have a crosswalk in the proposed rule that shows you all of the equivalent certification criteria that can be rolled out through upgrades for the 2014 edition. Starting with 2014, the reporting periods, calendar year or fiscal year, every provider will need to have EHR technology that's been certified to the 2014 edition that meets the new definition of certified EHR technology. But again, it will only need to be that quantity of EHR technology that they need to meet meaningful use and the stage of meaningful use that they seek to meet. So it's not going to be 100% anymore. Different providers could have different sets of capabilities that will still meet the definition of certified EHR technology. So we have a few changes to the permanent certification program, and I'm just going to go through these pretty quickly. We're changing the name to make it clear. There's no need for this temporary permanent lingo anymore, so we're just calling it the ONC HIT certification program. With respect to the base EHR requirement and including the privacy and security capabilities from a fundamental perspective, we are no longer requiring upfront certification of EHR modules to the privacy and security certification criteria. That was an area where we got a lot of feedback about redundancy, extra work with not a lot of clear benefit, and a lot of other challenges that I could go into more detail about. But that was an area where we felt we could revisit that policy, take a fresh look, and we've kind of redirected the policy outcome that we're seeking to achieve. We didn't get rid of any of the privacy and security certification criteria. Let me make that clear. Everyone still needs to have certified EHR technology with those certification criteria. Just so happens that they're part of the base EHR, however you get that, and I'll continue to move on because I don't want to eat up too much time. There are a few other tweaks that we made to make certification more efficient, Farzad mentioned. And then with respect to some for EHR modules and some for just EHR technology in general, we included some certification criteria that relate to reporting and capturing certain information to help providers get more data out of their EHR technology for the purposes of attestation or electronic reporting to CMS. And we also, based on the Institute of Medicine's Patient Safety and Health IT report that got issued in November, took a fresh look at what we could do in the area of safety. And so we've proposed a certification criterion related to safety-enhanced design that would focus on user-centered design processes being applied to certain capabilities for which EHR technology includes. And those we've prioritized them around 8 certification criteria that are all medication-related. So that's the first place where we're focusing our certification lever to take a first step towards safety-enhanced design and towards the application in the software development lifecycle of keeping best practices with respect to user-centered design in mind. And so some of those certification criteria are, I'm sure you would expect CPOE, drug-drug allergy interaction checking, clinical decision support, EMAR, electronic prescribing, and we revised the medication reconciliation certification criterion to actually be broader, so we call it clinical information reconciliation, which now includes the capability to reconcile medications, problems, and I think med-allergies, if I got that correct. So just another PSA on a few other things that we're doing. We're trying to enhance your public comment experience. We're going to make a Word version of our rule available, so this is a little bit of a pilot. The Federal Register version, once it's formatted in the tri-columns, isn't easy to copy and paste, isn't easy to massage, isn't easy to take, put it in your own PowerPoint presentation. So we're just going to make that available to you. And we're also going to be, when the rule gets published, we're going to have a comment template that lays out and would be useful to you, totally voluntary, up to you. If you think it's the helpful way to structure your comments, you can still include your policy discussion up front as part of your cover memo, et cetera. But in helping us expedite the turnaround and the disposition at the end, we do standards, so why not standardize the comment process? And we've laid out the certification criteria in a standardized template that if you do it in that, it would really benefit us and help us comb through the many hundreds of comments that we expect to receive. And so there are 3 ways to comment: snail mail, express mail, electronically through regulations.gov. That's our preferred method. We'll go ahead and post them and make them publicly available. And you can, if you want to see me again, you can hand deliver them to me in person at the Humphrey Building. I wouldn't say that that's the preferred option. And so we're also going to be making available grids and other types of education materials as time goes out. So that's it.
Great. I think we have HIMSS staff and our folks who can help collect question cards. Is that right? Confirmation from someone? So raise your hand. We'll have someone come by, take your questions, and we'll start to do that. We've been joined by Rob Anthony from CMS also, and Jess Kahn is here also from the Medicaid side of the house.
I just want to point out that we are going to have all the slides. I saw a lot of people taking pictures, but we are going to be posting the slides very shortly. They might even be posted for all I know, but they are going to be available.
As, yeah, right. I have been monitoring Twitter, Brian. So far, so good.
So they have cards.
Okay, so to go through two of the cards real fast. Question about the ICD-10, is it in our NPRM? No. So that was easy. CPOE showing unchanged for certification. Does that mean that CPOE for lab orders is not part of stage 2? Actually, CPOE for lab orders is part of stage 2. There are two big changes to CPOE for stage 2. One is we're expanding from medication to just medication, laboratory, and radiology. The other thing is we're proposing to get rid of the awkward unique patient, one order per unique patient denominator, and just kind of go with the natural, numbers of medication order denominator for those three types of orders. So those are the two big changes for CPOE. Go ahead, Steve.
So one question that I got, Don. Do vendors have any obligation to label their systems clearly with any exclusions, omissions? Will the ONC vendor list clearly indicate this? So current policy is that with respect to EHR modules, each certification criteria to which the EHR module has been certified needs to be will be indicated and is reported, and so that would be part of the certified HCT products list. So that would be transparently available if someone is looking up an EHR module to see what capabilities that they had relative to the meaningful use objectives and measures that they seek to meet. I can run through these pretty quick. The laboratory results interface specification was mentioned, but lab results shows is unchanged. For the ambulatory setting, we included that as a certification criterion because, as I understand it, the laboratory results, the LRI specification is currently designated for the ambulatory setting and not for the inpatient setting. So that's on the receipt of that information. So it's applied to it.
Let me,
Yeah. I'll continue on with that.
let me provide a little more depth to that. So the Health IT Policy Committee had recommended that we raise the threshold on the amount of lab data that's available to eligible professionals in structured format. And we discuss in the rule how a large portion of those lab results are from hospitals. And the Health IT Policy Committee had recommended that hospitals have a meaningful use requirement to submit when they report out lab results to eligible professionals, to outpatient providers, that they too have a requirement around doing so electronically according to the standards. We have included those standards in the certification criteria for inpatient, yes?
Which one?
The hospital lab?
Out.
Outbound from hospitals. We've included that in the certification criteria. However, we're seeking comment. We did not propose, as per the policy committee, that they be requirements for hospitals, and we're seeking comments on that piece. But there is an outbound side from the hospital side, to which the standards would apply, and an inbound on the part of the providers and the provider certification.
So I'm going to answer kind of a PSA one real fast. We asked for the time and rooms for the Thursday, Friday meetings I mentioned. HIMSS has been great working with all our last-minute craziness, but you can't print it out that fast. So it is on the web, but I'll just go out so far. So the one that's focused on meaningful use and the Medicaid changes, that is tomorrow from 9:45 to 10:45 in the Venetian showroom. The Health Information Exchange one is 1 to 2 tomorrow in Lido 3106. And then the clinical quality measure is the 2:15 to 3:15 slot tomorrow here in this room. And then Friday's payment adjustment and also focusing again on the CQMs is 11:15 to 12:15 on Friday in the Venetian showroom. And I believe that's also on the web. Obviously, it's not in your little handout because we didn't get it to HIMSS for that to be practical. Because yesterday feels like, right? So So those are the actual times for those presentations.
Okay, I have another question about adopt, implement, and upgrade for Medicaid, whether those provisions will be intact for stage 2. I mean, they're the provision that is in place for before you hit stage 1. So all Medicaid providers do start in AIU, then they go into a 90-day period for stage 1, then a year period for stage 1, and then they'll have 2 years at stage 2. So that is definitely maintained.
All right, I have one more, which actually prompted me to make a statement that I forgot to mention while I was speaking. So the question generally is that many vendors have gotten certified for meaningfully stage 1. These certifications expire in the fall, winter of 2012. Must they retest for stage 1 in 2013? So for the purposes of our certification program, certifications don't expire when there's no expiration with respect to a certification until a new edition of certification criteria are adopted. And so as the chart that I had with 2011, 2012, 2013, and then the line, and then 2014, if there's an EHR technology that's certified to the 2011 edition certification criteria, it's good through 2013. And the other thing that I will mention is that if you all can help when you talk with other folks, we don't certify to stages. Right, and that's keeping track with the new language that we have. We have 2011 edition certified EHR technology and 2014 edition certified EHR technology. So when you're talking about certification, try to talk in 2011 and 2014 edition. Don't talk in stage 1 certification or stage 2 certification, because in 2014 there will be 2 stages active, and they will just be tied. EHR technology will be tied to the 2014 edition certification criteria. As you can imagine, as we get out into stage 3, when there will be 3 stages active, we will likely have 1 edition of certification criterion again, either 2016 or 2017, and that helps keep constant and consistent interoperability progression as well.
So I'll roll through here 3 topics here real fast. So clarity on the first stage for when a provider can attest to MU attestation for stage 2. So stage 2, the soonest it'll start for anyone is October 1st, 2013. That's the fiscal year for hospitals. January 1st, 2014. It's full year reporting period, so the soonest we'd see any attestations back to us for stage 2 would be October 1st, 2014 for the hospitals, and January 1st, 2015 for the EPs.
And well, that'll have to be our last question if
Okay.
you'd like to pick
All
one,
right.
because I'm afraid I have the bad news of needing to wrap this up. Did you want to answer one more question?
Oh, sorry. I thought you meant that was the last one. So we'll go with the one that had the most cards. So we mentioned stage 1 changes. There are several. Obviously, I don't have time to go through all of them. They are minor kind of things we've heard from stage 1. There aren't new capability things for stage 1. And the other question is, does your certified EHR technology have to be recertified due to the changes? And the answer to that is no.
So big round of applause for our presenters, and thank you so much for attending.